Assalamualaikum, Darjaha, Vanakkam, and welcome to CEKU Inspires. A brief introduction of what CEKU is. It is UKEC's very own in-house publication where we publish articles written by students themselves and students in the UK, Malaysia, Ireland, and actually we embody student activism through the written medium. But recently, we're looking to diversify CEKU into a podcast series, which is UKEC's very own podcast. First ever podcast. We've never done a podcast before, but it's a trend where people like to listen to podcasts while they commute or they're studying, working. So here we are today. And today is an exceptionally special episode because sitting beside me is the chairman of the National Heart Institute, the chairman of UCSI Healthcare Group, the chancellor of Cyberjaya University, the former Director General of Health Malaysia, and I believe that the audience and everyone here can relate where during the pandemic days, this is a common household name. I remember back then I would study for SPM in my grandparents' house, and we would actually wait for the 5 p.m. announcement every day, and we would always have a different reaction. I enjoy listening and looking at my grandparents' reaction. They would completely lock themselves in the house, no contact whatsoever, but because maybe I'm their favorite granddaughter, they let me study there and for my SPM. And yeah, never thought that I would meet the person in the television right here in real life. But please welcome Tan Sri Datuk Sri Dr. Noor Hisham as our invited guest speaker for CEKU Inspires episode. So yeah, virtual round of applause. Tan Sri, would you mind maybe introducing yourself briefly? And for CEKU Inspires, we want to make it relaxed and informal. So would you mind sharing about the early years of your life in Malaysia? How was it back then till now?
Right, thank you very much. And first and foremost, I'd like to thank UKEC for having me this afternoon. And thank you, Bakis, for inviting me and then to have this informal discussion. And certainly, when I'm actually trained as a surgeon, and in 2008, I was appointed as the Deputy Director General of Health, in charge of medical profession. And 6 years later, in 2013, I was appointed as Director General of Health. Since then, I think I have, struck a balance between administration as well as a surgeon. So I still continue to practice since 2008, 2013 as the DG. Even as the DG, I still practice once a week, running my clinic on Tuesday and running my operation on Friday. So as Saturday and Sunday, I can attend to my patients. So I have not stopped practicing, so I basically, on both sides, administration as well as the technical expertise as a breast and endocrine surgeon. So I continue to contribute in administration as well as in academic, in surgery and etc.
Yeah, and that's really nice to know that you've chosen to continue doing surgeries even after retirement. So is that your life passion, and how did you strive? Is it something that you want to do for the rest of your life?
Yeah, once upon a time I wanted to be a surgeon, not only a normal local surgeon but world-renowned surgeon, and I have achieved that in terms of providing the services, training, as also academic advancement in research and publication. So that is my passion, and I've always wanted to be a surgeon. But in 2008, I was called by the top management in the Ministry of Health to take up the role of administrator. And at the age of 40, I'm still a very young and active surgeon. So, they tried to persuade me for more than 2 hours to take up the job as an administrator. But then the moment I walked out of the room, I said to the Director General, then you can keep the post. I'm not an administrator, I'm a surgeon. So I left. So then I realized that, in terms of administration, if the top management do not understand what we do at the hospital level, so it's, and decision and policy been made without understanding will bottom up. So there's a lot of gaps, during that period of time, and also my peers and fraternity was pushing me, why don't you just take up the management? The best management is bottom up and top down. So, if you have the power to create new policies, for example, to improve the services, and then you must understand what we do at the ground level. So that's the reason why I took up, but with one condition, I'm still allowed to continue my practice in the hospital at least once a week. And that was what been negotiated. And in 2000, at the age of 43, in 2008, then I took up the job as the Deputy Director General of Health in medical profession, so Medical Development Division. So that's where I think we try to improve the services at the hospital level and improve the environment for our doctors and staff, create a conducive environment so that we can provide good services, we can provide good training and education to our juniors, as well as continue the research and academic research and publication and etc. So that was my focus, to change how we do things better, faster, cheaper, safer to our population.
Yeah, and that's really nice to know that you have that mindset since in the early years of your career, because some people would immediately jump on the opportunity immediately when you have an offer with a big position or a title. It's not something that you get every day, but it's really refreshing to know that you value education and collecting experiences before choosing to take up that role. Can we also take a few steps back? And I think a lot of people is curious as to why you chose endocrine and breast surgery instead of other types of surgeries or fields in medicine.
Well, when I was in a houseman, so I have to, basically decide in terms of specialty and subspecialty, how do you decide to be a surgeon or to be a physician, etc. So there are a few, I spoke to one of my professors, so she advised me, number one, are you the type who likes to read or like to do? So I'm the types like to do rather than reading. So if you like to do, then the surgery is the discipline that you should take up, right? And if you're type like to read, then better take up to be a physician. So medicine, pediatric, etc. You read a lot, and then you investigate and etc. So that's more knowledge than action. So I'm a person of action. So I like to be hands-on. So then the next question is, do you have a fine skill or do you have a rough skill? In terms of, if you're a rough person, then you do orthopedics, you use hammer and etc. But if you're a fine person, then you do something like, ENT and then eye surgery, things, or neurosurgery for that matter. So that's, then I like both actually. Endocrine surgery, because you need to have a very strong background of endocrinology, meaning reading. So I can treat a patient, for example, using the knowledge of endocrinology, but I also can treat the patient in terms of operation. So many of the endocrinologists can diagnose the patient, but they cannot treat the patient, perform surgery, but I can do that. So I can have both sides, being a physician as well as being a surgeon. And I can actually treat the patient in terms of follow-up with diagnosis, then localization, pre-op preparation, intra-op preparation, and then post-op. So that's part of endocrine surgery. But more importantly, I think being a surgeon, there's a lot of the training that I get helps a lot in the administration. Number one, for example, you have to be calm. Calmness is one of them, because from time to time you need to break the bad news to the patient. For example, if there's if they have been diagnosed a cancer, for example, once you break the bad news, they will fall apart and then they will break down, etc. You have to be calm and firm in terms of to guide them, in terms of from the diagnosis to the treatment. So that's where I think engagement with the public is important. Engagement with the patient is very important, and you must be able to convince them, engage with the patient, explain the issues and challenges regards to the diagnosis, and then you must manage the expectation of the patient and the family members.
Yeah.
So if you can manage the expectation of the patient and the family members, then obviously you will gain trust. For example, you explain everything about the surgery, and then everything went on well as planned and explained earlier, then they build trust in you. So I think once you have the trust, then that's the beginning to grow the trust further. And that's where I think in surgery we do that all the time. And that helps a lot in terms of decision making. Surgeons make decision rather than delay the decision to the next day and etc. With the facts, evidence that you have at that point of time, you need to make a decision, rightly or wrongly, you still have to make a decision. You need to make a decision whether to operate or not to operate, right? You cannot say tomorrow.
Yeah.
There's no tomorrow. You have to make a decision based on that. Surgery or no surgery, you have to decide. So that's where I think the training that helps us to be more decisive administrator. Based on the facts at that point of time, as an administrator, you need to decide. And then decision is important to make a big difference in what we do. So no decision, remember, no decision is a decision.
Yeah.
So then you have to make a right decision based on the facts, science and data.
I really like how you mentioned you like to be hands-on, and we can see that you're someone who really likes challenges, right? Would you mind sharing with us maybe one or two cases where it was really hard for you, the surgery that you had performed, maybe the success rate is very low and then you have to break the news to the family? Maybe share it.
True. I think over the years you see all kind of cases and a wide spectrum of experience. I remember one case, a redo operation is the most difficult operation, meaning someone have done the operation and then now you have to do a second operation. That's the most challenging. And one day I think I got a referral from IJN to me in Putrajaya Hospital, and a case of follicular thyroid cancer. We all know that follicular thyroid cancer is a very vascular cancer. So first operation was done. But the second operation now is not in the neck anymore. The thyroid is not in the neck, but basically in the thorax, in the chest. So I always tell teach my trainees and etc. Sometimes you need to have a sixth sense to see whether things can, you have a feel, or some people call it a gut feeling, whether this case is okay, you can do it well, this case, although you have no experience yet, but you have the sense of feeling that, everything will go on well. But this case maybe, is difficult and
There's
etc. Something wrong and all that. So that is a skill that you need to develop a period of time. So we call it the sixth sense, we call it the gut feeling, and etc. There was one incident, I think, as a VVIP. He came to see me, and then he wanted a second opinion. Came to UK, and UK diagnosed him as a Cushing syndrome. That means there's a hormone production from the adrenal gland, and then the UK doctor referred him back to me in Putrajaya. So I received him and I looked at his case. Yes, he needed the surgery, but my feeling then was not really, good at that point of time. I could have, because he's a VVIP, I could have just list him for operation next week, but I did not. So I discussed with the family and etc. So the family decided, okay, we do the operation maybe in 3 weeks' time, so that he have a few meetings to attend, etc. So I agree with that. Although I can push the operation next week, but I did not. So I sensed something is not right at that point of time. And sure enough, next week he had a heart attack and he passed away. So can you imagine if I would have done the operation next week and patient had a heart attack on table, for example.
On the table itself.
Yes, right, yeah. Then that's the feeling that you can have.
Yeah.
So similarly, this case, referred to me from IJN, and then the follicular thyroid cancer. I was quite reluctant to operate because something is not right. I can feel it. My gut feeling or you call it sixth sense. Then I told the wife, this is going to be a very difficult case. But no choice. So we discharged him, let her and the family discuss about the case. Then we discharged the patient. 1 week later, he came back with a tube because he collapsed at home and then intubated and referred back to Private Hospital. Then the wife said to me, no choice, because really intubated, you have to do something.
Yeah.
And my gut feeling is still not good. So most of the time, even difficult cases, if my feeling is good, I'll do. And most of the time, 99%, everything will be smooth sailing. But this case, then eventually we decided to do the operation. Obviously, because it's not in the neck, the operation is in the chest. I have to split the sternum. That means cut the sternum and then open up, just like open heart surgery, and then remove the huge tumor, follicular thyroid cancer in the chest. The moment I remove it, because we know that it's very vascular, start to bleed, but there's no spurter, it's welling up from bottom up, so was so much bleeding. And it was for like 15 liters of blood loss. So every one of us, 15, 1-5. Normally, a normal person would have 5 liters only. So 15 liters, we have to transfuse the blood and etc. I was sweating during the operation, and then anesthetist was commenting or also sweating,
I can
pumping
only imagine
blood.
how panicked everyone was.
Everyone was very panicking in the operating theatre, so I have no choice just to pack and all that. And then my anesthetist already given up. He said that, in this case, I don't think can survive. So we immediately closed the wound and then we send it to ICU, and probably from there, we take on from there, meaning patient will not make it. So my assistant also, thinks that, this operation also, I think is going to, patient will succumb to the surgery and etc. So I also almost half-heartedly given up. So I just packed everything in and then we close up and then slowly remove the pack and then push the patient ICU. So the moral of the story is that anesthetist has given up, assistant have given up, nurses have given up, the surgeon half-heartedly have given up as well.
You've half-heartedly
because everybody have given up. So, but when we push the ICU, as I said, when the time comes, if your time comes, then probably, not even 1 minute delayed and etc. But this patient eventually, 2 weeks later, walked home actually. So which means everyone have given up, and even the surgeon half-heartedly given up, God has not given up, and patient survived the operation. So this is one experience, I think, that whatever we do, we need to fall back, tawakal to Allah SWT, in that sense that in terms of we do our best and let Almighty do the rest. Yes, that's right. Yeah.
And also, that's like one of the rare miracle cases, you would say?
Yes. And then every year, without fail, he will send me a Hari Raya card, a big Hari Raya card with the music. In those days, there's a music, right? So I was receiving the Hari Raya card for the next couple of years, right? From
That's
him.
really nice. Yeah, I really like hearing these kind of stories. Are really interesting, and I feel like that's what pushes doctors and how they choose to stay and do the surgery, because it's literally life-saving and helping people. It's a truly noble job, I would say. And after hearing all your stories about your surgeries you did, just before I move on to this question, do you even remember how many surgeries you performed over the years?
Well, if you look into it per year, I think we are almost touching those days. I was very active in doing surgery. Every week, do at least 4 or 5 cases. In those days, I still remember 2nd of January 1998, I was in Australia, and nobody works on 2nd of January 1998, So,
it's New Year.
New Year. So my professor made sure that, Hisham, tomorrow you are the only person available to assist me in the operating theatre. And we did a record of 11 cases operation in one day. From 8 o'clock in the morning to 8 o'clock at night.
That's
so I remember
one surgery in an hour.
Exactly. Every hour. So I don't even have time to drink coffee, in between cases, because patients
to even rest, because you might have to read the patient's requirement.
That's right. Yeah. So that was in the Royal North Shore Hospital that we did 11 cases in one day. And after a last case that we did was about finished about 8 p.m. And my professor told me, Hisham, I think you're very tired. Why don't you go home? I will do the post-operative round, That means to see the 11 patient before he goes back. So meaning he is staying to see the 11 patient and then instructed me to go home because I'm tired. So you can see that the kind of passion dedication and passion that she has.
That's amazing. I can't even imagine, because a lot of people out there, they want work-life balance, and after 5 p.m. you just want to go back home. But that's not the case for surgeons and doctors, because cases can come anytime. It's unexpected. And okay, we can already see that you're very passionate in surgery, but then you made the leap to become a civil servant. So what inspired you to make that big decision? Because you really like surgery.
Yeah, this was a very difficult decision to make, to cross over to do administrative work. And in fact, I consulted my professors in Australia. Then I was only about 43 years old. Then obviously he said that that's a big decision. Normally, surgeons would take up this role when they are older, maybe at the 50s or 60s, when they take up the administration job. But it's a tough call for you, tall order, to cross over. But then the pressure was from the fraternity to do something right, to make, policy making, as a surgeon, I can treat one patient at one time, at one point of time. But if you can create a conducive environment or right policy, you benefit the mass and the whole population, right? So that's public health. If you have the right policy, you can save the nation. Surgeon can save one patient at a time. So because of that, I think then I have to decide to take up. I was offered actually at age of 40, but I refused.
Very young.
So I rejected. But at the age of 43, then I see that implementation policy wasn't right at the ground level. So we need to change the policy to make the environment much better and more conducive to our staff. So I decided to take that role, but provided that I'm still allowed to practice. So that is my negotiation. So they said, okay, you can practice once a week. So that's what I have been doing for the last since 2008 until my retirement. I've still been operating both sides and participating in conferences locally, regionally, and globally.
Yeah, that's really nice how they can accommodate to your requests as well. And just want to know if you want to share with us any favorite moments you like to share while serving as a Director General for over 10 years?
Yeah, I mean, obviously everybody knows that most difficult time that we have faced was the pandemic COVID-19. So it took us about 3 years, and the most challenging period was at the initial phase in 2020, whereby at that point of time we do not have enough diagnostic kit, we do not have vaccine, we do not have therapeutics. And then how are you going to fight a war without a weapon, right?
Yeah.
So the only thing that we can do at that point of time is the public health measures, the preventive measures. So this is where I think we look into in terms of trying to avoid from being infected. There was a strategy initially. When we look into the strategy, you can use the herd immunity approach, meaning that you protect the elderly and the high-risk group and the young ones because their immunity is much better. They get, you expose them, in the public, and then they get the infection. Hopefully they recover from the infection and they build natural immunity. That was the public health in terms of herd immunity approach. We did not use that approach, so we thought that's very dangerous because we do not understand about the virus.
We're like playing with lives experimenting.
Right. Yeah. So what we did is we used the public health control and prevention and control method approach. So we also have a 6 months grace periods to learn from the UK and Europe what they have done right and what they have done wrong. So initially in Sweden and perhaps also in UK, they were using herd immunity approach, meaning hopefully the young population get infected and recover with natural immunity. But then they realized that even not the elderly, the young ones will succumb to the infection. So that was the learning lesson from Sweden. So we initially started with the prevention and control strategy, whereby meaning we try to avoid the public from getting infection. And this is why we want them to stay at home, avoid crowded places, confined spaces, put on a mask if you have to get out in the public, and etc. And because, why? Because there's no vaccine then, there's no therapeutic treatment then, and also diagnostics limited. So we only can diagnose about 3,000 patients using PCR tests then. So before we actually use the RTK antigen. So that's the measures that we can do, but it's all temporary measures. But when the challenge came in was I was informed by my colleague from Brunei that one of the participant from the tabligh group from Masjid Sri Petaling came back from Kuala Lumpur in Brunei and was diagnosed positive. So he informed me the participant was positive. So what we did is we rushed to the hospital, Sri Petaling Mosque. By then we realized that there was 16,000 people gathered in that mosque during the period of time.
That was a cluster in itself.
And 1,500 from foreign participants from Indonesia. There were about 692 participants then from India and other countries. So when we went there, most of them have gone back to their respective town or even country. So there were about 500 people still there. What we did is we swabbed everyone, we tested everyone, almost 80% positive COVID-19. So we know that it's a time bomb that, when they return to their own state or village, and then it's just a matter of time to spread to the family and then continue to spread locally. And also those gone back to their respective country like India and etc. So that was a real challenge now. And what would you do at that point of time? Because the incubation period for coronavirus normally is about 2 weeks. Now, if within 2 weeks, you see there will be a spike of cases from Perlis until Tawau.
But it was so fast.
Yes, right. It would spread like wildfire. So we advised the Prime Minister, probably we have to take preventive measures. People stay at home less, and we can control the infection at that point of time. So that's where I think on the 18th of March 2020, we started the first lockdown for 2 weeks because the incubation about 2 weeks, and then we continue for another 2 weeks, 4 weeks. And it works well because after 4 weeks, although when we look into the modelling, we are supposed to get a spike of cases, but it did not happen. Meaning
you were successful in containing
the infection and managed to bring down basically there's no surge of infection. The cases were 0 cases. So as I said, when your success leads to complacency, and complacency eventually leads to failure. Why? Because we thought that we can control the infection very well. Everybody starts celebrating.
But that was just the first half.
That's right. So once you celebrate, then you call for another election, the PRN Sabah. So obviously they think that we Ministry of Health advised the government then not to have the election. But then because the cases being well controlled, and obviously election is a must. So if it's a must, then you have to comply to the SOP.
But in this case, there's a difference. You need to now see what's the most important one. What's the priority now? Is it to go out and vote or to stay at home to prevent?
So because the infection rate at that time almost 0, right? So they think that the best decision would be no election at that time. But elections still have to be called for because human rights and etc. Then you have to comply to the SOP, right? If you can comply to the SOP, that's fine.
Yeah, that's right. I remember you explaining the guidelines and the SOP before people going out to vote.
Exactly.
But it didn't happen.
Because compliance was not there. So again, they break all rules. When they get campaign, house-to-house campaign, in terms of campaigning in a compact area, in a crowded area, and etc. So the infections start to spread. So that was the real challenge. And once that happens, we realize that we cannot depend on lockdown anymore, because lockdown is only a temporary measures. So we need to fall back on some solution and intervention, mainly a vaccine. So we have to go to purchase the vaccine, and get the vaccine from around the world, so that we can actually protect our population.
But it is such a high stress situation and an uncertain one at that, because being in the health ministry, you can only do based on your next action is based on what you have and at that point of time, right? At that day, you can see there's infection, but there's no vaccine, and that it's never happened before. So, how was it in the ministry, at the hospitals, where it was so uncertain, but you still have to push forward because if you don't stay strong, then the society will eventually, there's more death cases.
So initially, I think we managed to contain the infection very well in the phase 1. But then after the Sabah election, there was a spike of infection coming in, and also fatality is very high. So every day we documented about more than 400 to 500 deaths a day, and even the mortuary is not enough space, for the bodies. So we need to rent in a container. One container we can probably place for about 45 bodies now. So we have 5 containers in the hospital Kuala Lumpur then. So the death rate is very high. So we then decided to get the vaccine as soon as possible, and difficult to get the vaccine because the rich country buy all the vaccine. So we need to negotiate and get the vaccine.
There's a shortage of vaccine.
Shortage of PPE, shortage of gloves.
But then the price was high.
Yeah, price was high. So we bought the vaccine in December 2020, but vaccine only arrived 6 months later, in stages. So I think once we have the vaccine, then we started to have a national immunization program, and then we managed during a short period of time to vaccinate a large population in Malaysia. And with that high vaccination rate of more than 90%, so we can see the decoupling effect, meaning the infection is still there, but the fatalities have gone down. So that is a good sign that shows that the vaccine works. And we also realized that at that point of time, because the vaccine is new, we do not have the long-term, records of the vaccine, whether the safety of the vaccine, etc.
It's been tested properly? Like, was it fast-tracked?
It was tested properly, but then we still need to long-term results. Like, for example, today we know about long COVID and etc. But we have a 6 months of grace period to monitor countries that have used the vaccine, for example, in UK and in Sweden, etc. So, which means we managed to use the vaccine, and then we look into the evidence. Some of the vaccine that we have from Pfizer, Moderna, from Sinovac, and etc., and AstraZeneca as well. So we managed to vaccinate our population, and then managed to bring down the fatality to less than about 10 cases a day. So that is a big achievement from the government then.
That really is a big achievement. But I also remember back then when the vaccines were new, and then the government suddenly said it's compulsory for everyone to take it, of all ages, like from children, then senior citizens. And then some people, they were very skeptical with how the vaccine is. Some people would just blame it, the side effects is worse than before they took the vaccine. How would you respond to that? Is it true that the vaccine is the cause of some deaths, or how people get a different kind of disease that they've never had before? So how is it true? Actually?
Well, we have never made the vaccine compulsory, right? Although there were mooted the idea of making it compulsory, but then it's highly encouraged and voluntary at this stage as well. So at no point of time that we made the vaccine compulsory to all. but we highly encourage one to receive the vaccine. There are many types of vaccine at that point of time. So now we know that the effectiveness of the vaccine. For example, like Pfizer vaccine, we realized that it lasts about 9 months or so before there's a waning of the antibody. Sinovac, after the 4th or 5th month, then the antibodies start to wane. So that's where I think then we realized that certain vaccine works better than other, and also the combination of vaccine, meaning you give a Sinovac, then followed by a Pfizer booster, for example, then the antibody lasts longer. So I think that's where I think we learn daily. But all vaccine have side effect in terms of local effect, for example. Or then we have this, monitoring of the performance of the vaccine, any complication, etc. We will take in and then you study about the vaccine. Because its reaction to the vaccine individually may differ from one another. But the common local side effect will be in duration, pain, and etc. But we also need to monitor in terms of whether the vaccine can cause more than that. So there's a group been formed, independent group been formed in the Ministry of Health to look into the adverse reaction and whether it's related to the vaccine or not. So I think they will advise us accordingly.
Yeah, and actually I also remember how some Western news outlets actually mentioned that Malaysia is one of the best countries in terms of handling the pandemic. And actually that's also because of how calm and collected our government was under your leadership. Why is it that you managed to remain calm, or is it something that comes from the health ministry, or is it something that you really want to emphasize on doing throughout the pandemic?
No, I think more important is that we know at that point of time, because this is a new infection spreading like wildfire, we have to rely on facts, science and data at that point of time. So whatever we know at that point of time, we need to make a decision then. And I mean, calmness is basically when I look into the camera, I assume that I'm talking to one person, one family, right? So, and try to explain issues and challenges regards to the infection, regards to the vaccine, and then try to manage the expectation of the public. And the communication that we had during a press conference, we used simple language.
Yeah, it was easy, very easy
for
understand.
People to understand. For makcik in the kampung, makcik-pakcik, auntie, uncle and all that, they understand the simple language. We cannot use the bombastic medical language and etc. And manage the expectation of public, because there's a lot of fear of this new infection, and when the death rate is very high. So how do you handle the fear and create trust now? Try to build trust in the public to the Ministry of Health. Can you imagine if the public do not trust the Ministry of Health? That's the beginning of the end of...
They would do whatever they want.
Exactly. So I think that's where the engagement is important. Daily engagement to explain issues and challenges, and also open up for questions and answers. So when they ask a lot of questions and then continue to repeat, some questions been repeated again and again. But you have to answer it again and again. Every day to reinforce, and that's where the behaviors start to change. Behaviors, you look into behavioral science, is number one, you must explain in a very simple, short messaging to the public. Second is continue to repeat it again and again.
So that it's stuck in people's brain, they remember.
That's right, they remember, and then once they understand, then the behavioral change will come in. And they must be able to understand the disease process and all the questions that they have. You have to make sure that you are able to answer to them. If not, then you just need to find evidence. In fact, in April 2024, there was a publication in Lancet, and it was mentioned very clearly that Malaysians have done the best in terms of the pandemic COVID-19, sharing the data and all the good practices been implemented in our country. And that was the publication not from us, but from the Western community. So which means that, that is an, appreciation of what we have done, a recognition of what we have done right. And obviously we can learn from this experience, leverage on this experience to strengthen our healthcare in the future. And one of the lessons learned here is that, you know, when we purchase the vaccine, we purchase on behalf of one country, 32 million population. That's not good enough because you do not have a bigger volume. We learned from the EU, when they purchase the vaccine, only one person able to, you know, negotiate on behalf of 30 countries. So one person, and so EU represented 30 countries and the bigger volume. When you have a bigger volume, that means your price of the vaccine you can negotiate lower, and the faster delivery of the vaccine.
It's in bulk.
Simple.
Yeah.
If only we can use the ASEAN platform for negotiation.
We didn't use it.
We didn't use the ASEAN platform. So if only we can use the ASEAN platform, Indonesia, Thailand, we have bigger population, we can bring down the vaccine, the cost of the vaccine, and perhaps a faster delivery as well. So I think small countries like Singapore or Brunei, they have to purchase the vaccine at higher cost. Volume is smaller.
Because, yeah,
that's right.
Smaller country.
So this is something that we can learn, and now we need to really look into the ASEAN platform, because we are the chairman of the ASEAN next year. And then if we can actually work together in terms of the procurement, pool procurement, pool training, that would be advantage to our region. High impact, reasonable cost, and good outcome.
This is definitely something that we could have done differently back then, but also it's good that we realize this now so that we can be prepared and we can do this in the next pandemic.
That's right.
Is it true that there will be more pandemics to come?
Yeah, my fear is that we have forgotten of our experience of handling pandemic COVID-19. There's definitely the next pandemic will come. It's just a matter of time when it will come, because now we are also looking into antimicrobial resistance, for example, bacterial resistant to antibiotics and etc. And the virus, the COVID-19 virus, have mutated more than 600 times. Now there's no new variant.
600.
No new variant, but there's a subvariant, subtype of the Omicron, for example. There's no new variant coming in. But what we fear is that the virus will continue to evolve and mutate, and until there's a breakthrough that our body is not able to detect that virus mutation, and then there will be a spike of infection again. So until today, although there are subtype mutation, but our body is still able to protect against this mutation of Omicron. But I think the fear is that the virus will continue to evolve, and it's just a matter of time we'll get another epidemic or even a pandemic.
I see. And also, just curious as well, under your leadership and you being the person in the health ministry itself, and you've been there since day one, so you've seen how unexpected, uncertain everything was. But when was it when you realized, maybe an unforgettable moment where you realized we can actually recover from it? Malaysia can do it.
Well, at that point of time, we do not know in terms of the outcome whether we can handle it well or not. But what we did is we follow science, facts and data, and we try to optimize the resources in Malaysia, for example. We are very divisive in terms of public and private, and there are big wall between the public and private. During the pandemic, we knocked down the wall, so we need to optimize resources. COVID cases been handled in the public sector. Non-COVID cases we refer to the private sector. And the private sector loaned us the equipment, for example, ventilators and etc. More than 1,500 staff from the private sector crossed over pro bono
to the public
to assist us. And obviously, we need to thrive on creative ideas and innovation. China can build a hospital, 10,000 beds hospital in 10 days. We do not have that kind of capacity and capabilities to build a hospital in such a short period of time. But we have creative ideas and innovation. What we did was we transform, exhibition center like Maib's, to 10,000 beds in a field hospital within 1 week. And then we started to use all this exhibition hall in the community to become a field hospital and then to place the COVID patient, etc. So again, thriving on creative ideas is very important, and a lot of things in terms of how do we use our skill, knowledge and innovation in terms of to adapt the challenging environment then. So these are some of the things that I think we need to look back in terms of how we can enhance it to strengthen our existing health system. But my fear is that many of us, the public as well as the organisation, have forgotten about the pandemic and moved on. So these are the important lessons for us to be prepared for the future, because if we are not prepared again, if we do not leverage on this lesson learned, then we're going to repeat history again,
it's like start
day one again. That's right. So again, we also need to enhance the collaboration with the public and private, and also at the regional, using the ASEAN platform. So can we start negotiating with our member states in the ASEAN to look into how we can pool together the procurement of certain medicine, how can we pool together in terms of training, and make sure that every country have their role, so that and that will enhance our response in future.
Certainly, I truly agree with that. And we'll have a short break. Okay, welcome back to the episode. We had a short break, but now, in the first half, we talked about Tan Sri, his personal life, his passion on pursuing endocrine and breast surgery, and then we shifted to the COVID-19 pandemic and how it was back then under Tan Sri's leadership. And now we're going to explore more on issues on the ground, what the doctors there are experiencing, and certainly Tan Sri will have a lot of opinions and insights that he can provide and maybe clear up with us. So building on the COVID-19 experience, Tan Sri mentioned that is it the first time where public-private system actually came together and broke the wall that before they separated them. So it just proves that we can have that collaboration. And so what is some other potential collaborations that you think public-private can do in the future?
Now, that's the reason why we came up with the white paper. The white paper is meant to address the healthcare transformation in our country. We've been talking about healthcare transformation for the last more than 40 years. But I think when we table the white paper, we need a bipartisan support from both sides. That, regardless of the Minister of Health of the day or regardless of the government of the day, then, this is something that we should do to transform our healthcare, meaning to integrate our healthcare, the public and private sector, so that we optimize the resources in the country, whether it's manpower, equipment, etc. So rather than looking into sector, we have to look into the country. But to do so, we must address the issue of financing. Meaning, now the rich today, they can go abroad for treatment, they can go to the private hospital, but some of them are also coming to the public hospital. Meaning, in the past, for example, I get quite a substantial referral from the private sector to a public hospital, and that's the reason why we set up the full paying patient to cater for this public-private patient. But the poor have no option to go to the private hospital because they only have the choice to come to the public hospital as well. Now, can we optimize the resources on both sides? So, in the Ministry of Health, we have started the full paying patient. We have more than 15 hospitals have a full paying patient. And then we did an audit recently, and audit shows that this is something is workable. We can actually increase the pool in the full paying patient in the public hospital. But now I'm in the private sector. We also have started in the private sector a public wing, meaning that we accept patient referral from the public hospital. And then negotiation has been done in terms of the pricing and all that. We keep to the minimum price that we can charge to the government, because although the public sector, you pay very minimum amount, the healthcare cost of surgery and etc. is not cheap.
Yep.
It's subsidized by the government. So I think if we can integrate that, that would be the best. But more important that if every one of us have an insurance cover, for example, you can go to the public sector or the private sector. So cost is not an issue, but you can crisscross between public and private. Now, if you can crisscross between public and private, then you go for the quality. If the quality is good in public, you still go to public.
Yes.
If the quality is good in private, then you go to the private hospital. So the healthcare will be driven by quality of care. And obviously, the pricing of certain procedures and etc. been spelled out clearly. I think that is the way forward for us to transform our healthcare so that we can optimize the resources, manpower, equipment, etc. in the public sector and private sector. So most important is manpower shortage and etc. now in the public sector because many have resigned to the private. How can we continue to utilize the resources in the public and private sector as well? So I think we need to look into the perspective of the country rather than the sector. Yeah.
Certainly, and that's actually a really good step forward because before this, when people just rely on public hospitals, especially the underprivileged people, they have to wait long queues, sometimes months,
Yes.
to even have that surgery. So
Right.
this is a way for them to get access
Yes,
to
right.
that surgery at a faster rate. And is that something that's been implemented across a lot of hospitals in Malaysia?
So we are looking into universal health coverage and looking into accessibility, affordability, safety and equity in terms of crisscross between the public and private. And it's not new. Actually, we have the public sector have outsourced some of the services like hemodialysis. We have been doing that for years. Cancer treatment, because in the Ministry of Health, they have 5 radiotherapy departments, not good enough. So we have actually outsourced to the private sector as well. So it's been done in the past. But now I think, how can we optimize the resources from both? But the issue now is, for B40 is no issue. Whatever healthcare system, it is a responsibility of the government for the B40. But for the M40 and the T20, they have option now. So whether, how do you address them in terms of the financing part? Maybe we look into the employer with employee health benefits, for example, or they have insurance cover for them to crisscross to the private sector. So I think these are the things that needs to be addressed because the current health system is not sustainable. We know
That's
that.
true.
Because everything is subsidized by the government. You only pay 1 ringgit to go to the hospital, 5 ringgit to see a specialist. Surgery cost maximum will be 300 ringgit, for example. So it's not sustainable. It's not cheap because it's subsidized by the government. But again, how can we look into optimizing our resources, the crisscross between public and private? That is the white paper that we hope that will transform our healthcare in the country.
Yeah, and also I feel like it's truly a solution that it's worth exploring more on and refine more. Because when you mentioned that the public healthcare service, like 1 ringgit, 5 ringgit, it's because it's too cheap, then a lot of people would tend to resort to those government clinics. But then there's another problem whereby not everyone can get access to the healthcare because too many sick people, but then everyone is going to that cheap alternative.
Yeah.
So is that a way for us to provide a solution for those who cannot afford the service, then they can still get access?
So now with the current system, now the government is outsourcing some of the services to the private sector. So the private sector have started this public wing to accept patients from the government hospital. For example, waiting for heart surgery, there are about 600 to 700 people waiting in the public sector. Now they have outsourced this to the private hospital, not only IJN, but also UCSI Hospital, KPJ, and a few hospitals accepting cases to decongest the waiting time in the public sector. So I think outsourcing is one solution, but it's not it's not complete. because it comes under the public sector and financing. So we need to have everyone to be insured so that they can crisscross between public and private. So now I think the cases is just to decongest the public hospital and outsourcing into the private. And outsourcing services, we have been doing it for years. For cancer services, cancer care, radiotherapy, hemodialysis been done. But I think we need to look further in terms of optimizing the resources from both sides.
Yeah, that's really good to know, knowing that it's been done before and we can refine this procedure better so that we can have a wider range of service for the public. Now, we've talked a lot on the public's perspective and their access to the healthcare, but then now let's look at the service provider, the doctors themselves. How is the working condition in public clinics, for example? Because I went to government clinics when I was in high school because they sent us there. I was in boarding school. But then I can really observe how the staffs were not really welcoming. If anything, they look really tired, like they're fed up working there. They just want to go back home. What is happening? What's the issue here actually?
Well, I think you look into the public sector is, I tweeted this way back in 2017. We are underfunded, understaffed, and then underpaid and overworked, and our system already been stretched out, right? So that is a big challenge in terms of us to maintain good quality care. And because most patients will come to the public sector, then you have issues of congestion. Once you have congestion and then overwork in terms of our staff, and obviously then the challenge is to continue to provide as the best care as we could, but you have a long workload and you try not to create problems. Doctors have to make sure that safety comes first. First, do no harm. But when you have volume of patients, and then this is the challenge that we face in the public sector. Having said that, I think public sector is still the best place for training, to do research, and to provide the services in your field of expertise. But we need to control the volume. But unfortunately, we are not able to control the volume. And then when we have long queues, long congestion, even I was informed that waiting for open heart surgery, 10 to 15% of the patient will succumb to the illness before the surgery, for example. So now there's no choice but to outsource this to the private sector to reduce the congestion. So we need to address the issue of congestion and how best we can optimize the resources today. But unless you change the health system, but you cannot change the health system by piecemeal. For example, 1 ringgit, you increase to 10 ringgit. You cannot do that. That's piecemeal because you're not changing the whole system. So we need to have a holistic health transformation rather than piecemeal, and piecemeal wouldn't solve the problem.
Yeah. It's really interesting how you advocate for a solution where we do a whole structural reform from like the service in public clinics to maybe access to complex surgeries at hospitals. How do you envision we do this? Maybe because it's something that requires a lot of effort and time and everyone to be on board on this idea. It's something that it's hard to change people's, they're comfortable with the system now.
No, I think number one is that the service, we look into integration of services. For example, during the vaccination being done in the GP clinics, for example, in the private sector. So it helps the government in terms of the scale of the vaccination using the private side, private sector for us to enhance the vaccination program. So that's been done. And more importantly, is that how can we optimize the resources on the private side using the GP, during the private hospital, and if we can do that, we can reduce the congestion in a public hospital. But the issue now is, who is going to pay? Like vaccination, not an issue. Government is paying for the vaccine. Government is paying for the service. Then you can actually extend it to the private sector, private hospital, private GPs to do the vaccination program. Well, but the government is not the insurance company, right? But for B40, yes, the government will step in. For emergency cases, because of COVID-19, government step in, pay the vaccine, everything. So we don't pay the vaccine, for example. But these are the challenges. But what about surgery and etc.? So we need to look into how we can optimize the resources to address the financing. So I think important for us to address the financing, to cover, so that one person can crisscross between the public sector and the private sector.
Yeah.
So in that sense, the public sector also, probably will be more sustainable with the new financing available, and also the private sector. I think integration between the public and private. We need to learn from the experience of other countries like in UK. They are buying services. What we can learn from them, what we try to avoid from happening, for example, in UK. Taiwan already started the health financing. Even Indonesia have started the health financing, because I met with Professor Ali. I think he's the CEO of the health financing in Indonesia. It covers for more than 230 million population. And one day they process claims, about 1.6 million claims a day. So they have done it. So I think it's about time for Malaysia to review our healthcare system and transform it to be better, faster, cheaper and safer.
Yeah, and I think we can all agree that this is something that Malaysia should seriously consider, like a whole structural reform. But I think to a lot of people out there, especially doctors working in the hospitals, maybe they feel like this is too far-fetched, because we have issues and problems right now, that other issues that can't even be solved. So for us to do this whole structural reform, it's quite like, to them maybe it's impossible. So let's talk about your suggestion earlier. You want to crisscross public-private doctors and allow them to transition to cross over the sectors. But then we also have the issue right now where we don't have enough permanent positions in the public sector, and how there's also a stigmatization whereby if someone from the public sector, they resign and then they want to go to the private sector, it's not praised. So how do we go about this?
Because at the moment, our healthcare system is dichotomous healthcare system, public sector and private sector. So if you have these two systems, remuneration is much better in the private side. I use the term, you work less and you earn more as compared to the public side. Obviously, many of the doctors will eventually cross over to the private side. So what we did in the past is we tried to retain our specialists and doctors. So by providing a conducive environment, and then by allowing them to practice in a full paying patient, so they have extra income. We also allowed our doctors to have one day a week practicing in the private side. That's to mitigate in terms of crossover. Yeah. That means, and the advantage in the public sector is that you have loads of patients in terms of providing services, and the experience that you gain much higher as compared to the private, and also for clinical trials and research. And also we are involved in training. So now the private sector is beginning to involve in training and research as well. But we try to optimize it. So I think if you can work in the public hospital, like in HKL, you can work in any hospital in the world. So I think the experience is there. We need to optimize the resources and make sure that integration of services is important. So I think we need to look into the financing issues, we need to look into the training, research issues, and crisscross between the public and private. That's what the pandemic COVID-19 have taught us. The lesson learned, we need to leverage on the lesson learned to strengthen our healthcare system further. Yeah,
that's really true. And I truly believe that a lot of doctors out there, even medical graduates, they want to go through that training process. They want to learn and they want to improve themselves and climb up the ladder. But talking about conducive environment, right? A lot of doctors on the ground, they have this common experience whereby even a study on personality traits and workplace bullying among contract trainee doctors in Malaysia done by the UKEC Medical Centre, a lot of general surgery, people from the general surgery department complain that there's a lot of verbal abuse going on during training, especially from the medical officers, especially if you're a contract doctor, you experience a really hostile environment, but they really want to gain that knowledge. So how do we change this if we can? Because it's like embedded in the culture.
So the problem now, I think we can see that because there's a congestion in the public sector, and the specialists, they try to minimize in terms of, complication and etc. And obviously, we follow the oath that first do no harm, prima non nocere to our patient. So in order to make sure that you can deliver and do no harm to patient, so you must train and make sure that your doctors can comply to the service requirement. But again, once you have volume of patient coming in, there will be a very stressful environment for everyone, and you want to make sure that you provide the high quality of services and minimize the mistakes, for example. So obviously the pressure will be there, and because this pressure eventually transcends into like a bullying in terms of when you've been told off, or things like trying to avoid from making mistakes, for example. So the pressure is built up to the head of department and to the seniors and to lower down. So I think these are the issues that we have when you have long waiting time, and then congestion, and also limited resources that you have, but you still need to provide utmost quality of services and the care. And that is the issue. Then how can you provide a conducive environment when you have a long queues, for example? So this is where I think when the quality will compromise, and then once the quality compromise, responsibility comes back to the senior, and that's where I think indirectly the bullying comes in and etc. to make sure that they comply and make no mistake. But again, sometimes overboard. Some specialists, they went overboard, and then becomes more personal, or the bullying become like an activities as part of the department. I think these are some of the things that we need to change and to develop to become more conducive. But you need to highlight and also address the issue of the long congestion first. I think that is the key. But I mean, maybe some personally there will be one or two all out for bullying. Then we need to basically identify them and then take them out of the system and to train them back again. But our responsibility is to train the junior. The way we train is different. Those days is top-down, very authoritative way of training. But today you cannot use the authoritative way of training anymore because the junior will complain. You need to be more conducive from bottom up rather than top down. This is a way, again, the new generation, you cannot force on them, you cannot. And those days, again, they don't like to hear this term, my time, my time. I know when I was in training, you just very, follow the orders, basically very authoritative way of conducting the training. But now it must be a bottom up as well. So how do you strike that balance and to create a conducive environment?
It's really nice because after hearing your answers, actually there's a link in every issue that's happening right now. Because in order for us to reduce the stress, to reduce the hostile environment, we need to address the huge volume influx of patients in the hospital by addressing and actually implementing the structural reform that you brought forward earlier. So actually it's not really an impossible thing or like a far-fetched solution for us to address the structure and consider public-private crossover. So it's all linked together actually. So also talking about training, how you mentioned now we need to do it differently, but I understand that in Malaysia, the training process takes longer than in the UK, like 4 years, but then in the UK or in Ireland, they only take 2 years. So why can't we improve our training system?
Now the training, we look into the a whole aspect of training. So we try to standardize now in terms of the experience. It's not only paper qualification, but also the experience. So we already have a national training board. We look into the training program. How can we use the training platform locally and standardize it overseas? So if you have 2 years experience and compared to 4 years experience, that will be a big difference, right? So we need to standardize it. So we have a national curriculum, and we hope that we can actually, those coming back from overseas have to fulfill the requirement as well. So say 4 years for everyone, 4 years will be the same period of time, because we want not only knowledge but also practice, clinical experience as well. So longer you are into the specialty or subspecialty, the better you'll be in terms of the experience.
Yeah, that's true. But also because of it's not aligned, the training system and the years of experience is not the same. So some doctors, a lot of doctors, they choose to remain in the country where they're studying. What's your opinion on that? Because some may comment like it's brain drain. This is something that the government wants to overcome, where we need to attract talents back home. But I believe you have a different take on this.
Yeah, I think, we are sometimes penny wise, pound foolish, right? So if we send our doctors overseas, and once they are qualified, when they come back, they're competing with the local as well. So, if we can expand and advise those training in overseas to continue their specialty and subspecialty, and then once they establish themselves, spend a few more years, then if they want to come back, then we'll facilitate. So when they come back, they're not competing because they're really a specialist. Now, when you come back, you compete with the local for postgraduate training. That will be challenging, because now the waiting time to join the masters, I was told, more than 5 years. Those days, surgery, probably I joined probably a year after housemanship, but now I heard some of them been waiting for 7 to 8 years before.
Which is why they choose to stay, because they don't want to wait for 5 years.
Because you come back, then you are competing with the locals. So if you can have the opportunity to train, to do postgraduate education in UK, for example, why don't you do it now? Then once you have done your postgraduate education, and then you have a few years experience, and then should you want to come back, then we will facilitate you to come back. Right? But establish yourself in your field, your area of specialty, whether specialty or subspecialty, and establish it before you come back. And that would be much more complementing to our healthcare services in Malaysia, for example, because you're not competing for a place to train. You're coming back as a specialist to provide the services. So I think now we need to train more, because we have more medical officers now, and then limited training capacity. So we need to use other platform of training in UK, Australia, and etc. So this is another way of looking at it, and then probably to enhance our healthcare system in time to come.
And also, in the previous episode with Dr. Carl King Yong, he's actually a consulting gastroenterologist at St. Mary's Hospital, and he has quite a different opinion on brain drain issue as well. He believes that doctors and specialists, they can still give back to Malaysia while being outside of the country, because it's globalization now, everything is online. So what do you think about that?
I think I support that. When I was actually involved in Talent Corp, I always advise our students not to come back. Climb the ladder in whichever country you're in, and then establish yourself to become the top management of that department, or hopefully one day become the head of the department. And obviously you will take more Malaysian students, right, in terms of the training, because the big departments will accept fellows from all overseas. If you are the head, obviously you will have a soft heart for Malaysian, to come and do the training here. Then we will train more people in UK, because you are from that system. You rise to become the head of department or the top management of that department. Obviously you can actually encourage more, take more Malaysian students for training, for attachment, and etc. So that is what progress is all about. So, but more importantly, you can contribute back indirectly by training more of a Malaysian in UK, for example. So I think that's how we look into, in terms of how we can provide a good quality of care. But should you want to come back, then we'll facilitate, right? But should you want to continue to develop in other countries, for example, UK and Australia, by all means, I think that's a platform for us, because we don't want you to come back and you get frustrated, because you're not able to meet your requirements and etc. And then that's beside the point. More important is that you can establish your role in the medical services in UK, and you can actually accept more trainees and accept more attachment from Malaysian, and also do a lot of clinical trials and research. And you can actually bring the clinical trial research, to expand it to Malaysia as well. So I think we are looking at different perspectives of how we can enhance the healthcare of our people in terms of training, services, as well as research.
Yeah, actually that sounds really great, because not only can they learn other procedures that are not available back in Malaysia, you innovate, you're exposed to these kind of technologies, and you also build a network like you mentioned, and you can increase more Malaysian talent abroad and have them share it back to Malaysia. But I feel like some of the people in our audience, they feel like this is something that is time consuming. So, but in Malaysia we have this issue as well, where we lack specialists, especially when senior consultants, they retire, and then we lack all the specialists who choose to stay abroad. Maybe they want to come back, but that's like 5 years later. So how is this going to help us, because we lack the specialists in Malaysia?
Well, you look into, in terms of specialists, it's a continuous engagement and training process. And we need to really look into the retirement age as well. So our retirement age is 60. If we can retain the seniors, for example, in medical education, etc., they can stay longer, so they can provide in terms of the training. We also need to bring in the private sector, the specialists in the private sector, to be involved in training. And obviously, engaging with Malaysian abroad, and they have been appointed as professors, etc., or as trainers, and they can do the training in UK, for example, or they can come back to Malaysia to do the training. I think we need to engage more of our trainers, and hopefully we can enhance the local program.
Yep, I truly agree, because it's not an issue that we cannot solve. There's always an alternative where, like you said earlier, crossover between sectors, and then maybe considering extending the retirement age. But I think everyone here can agree all the solutions that we discussed earlier. These are big decisions, hard decisions to make in the system. So how do you make, being a former Director General and still serving as a surgeon, how do you make hard decisions in life? Because not everyone will be satisfied with what you decide on.
Well, we can advise, as a civil servant, we can advise political masters in terms of the do's and don'ts. But at the end of the day, we need political will and political commitment, to make that decision. So, and obviously, whatever decision you take, there's a pro and cons, but you need to study it, and then hopefully that we can implement it for the betterment of the healthcare in the country. So obviously, I think what we have discussed is options, and the political masters will have to decide. Then our role as a civil servant is advise the political masters.
That's what we've been doing all this while as well. But in the end, the people who are in power, they will decide whether or not they want to take in these suggestions and actually implement and bring that change. Because also we need to understand that the healthcare sector is really important. Maybe you want to give some comments on how maybe people don't realize that it is a big investment to make, and it's something that we should be doing, actually.
Well, pandemic COVID-19 have taught us health is wealth of the country, right? So you can see during the pandemic, our crisis, not only in health, but also in economy, in social, and also in political crisis. So I think at the end of the day, we need to make sure that we can deliver. Healthcare is a very important sector, and every sector is a healthcare sector involving everyone. I think more important is that health is the wealth of the country.
That's certainly true. And I think that speaks for itself. I think there's nothing else holding us back. We have all these brilliant solutions. And just last question I would like to ask. You've went through so much throughout your life, and I'm aware that growing up it was different for you, and now you decided on becoming a surgeon, and then suddenly offered to become a civil servant, and now you're finally back being a surgeon. But what is the biggest motivation for you to just move forward, and what is something that you hold on to?
My advice to everyone is that you first you have to be sincere to yourself. Whatever you do, you must do it sincerely, and then you must have passion and dedication in whatever you do. So, like me, my passion is basically in surgery. I love to do surgery, and and that's part of what I intend to do for the next couple of years. And obviously it's very rewarding. Why? Because patient comes to you with a problem.
Yep.
And by doing the surgery, there and then, next week, I can solve the problem.
Yes.
Like being a physician, if I treat diabetes, I'll continue to treat diabetes again and again without solving the problem, right?
Yeah.
But only to maintain good health, etc. So surgeons, I think you can actually change the course of the disease, for example. You can manage it well, you can treat the patient, and it's actually very rewarding, especially in the endocrine surgery, because you can actually solve the problem for them. But more importantly, if it's looking into the healthcare in the country, we hope that we can provide good quality of care and more and sustainable in time to come. Sometimes healthcare is good, but it's not sustainable because of issues of funding and etc. I think we have the potential, and then we have good points. For example, a lot of British citizens, for example, coming to Malaysia, they can access to healthcare very fast. For example, you need to see a doctor or surgeon, there and then they can get an appointment and see the surgeon. And I was told here you have to wait for the appointment, maybe weeks, maybe months. But there in Malaysia, in the private sector, they can make appointments straight away, attended to, and the problems can be actually dealt with as soon as possible.
Yeah.
So that is something that we must maintain, but we need to basically integrate between the public sector and private sector so that we can optimize the resources of facilities in terms of congestion, in terms of manpower, in terms of expertise. If we can do that, crisscross between public and private, and then we are looking at the country, not at sectors anymore. I think that is the key for integration. But for integration, we need to look into financing.
Yeah.
How can one poor patient crisscross to the private sector, and how will it be funded? That is important. So if we can actually address that, I think probably we can address the whole transformation of healthcare in the country.
Yeah, and that's really reassuring to know that Malaysia is already ahead. Like our healthcare system and our services is already good. But if we are able to address the structural issues, provide all these reforms, and just have that open mind to actually do something different, then I think Malaysia's healthcare system will be exceptional in the future.
Well, WHO have acknowledged the healthcare system in our country, and in fact, they have actually named Malaysia as one of the countries that have succeeded in terms of handling the pandemic COVID-19 very well. And as I said, published in Lancet, also acknowledged what we have done. We are among the few countries that have been acknowledged in the publication. So I think we can do wonders if all of us come together as one, and we must have strong political will and commitment.
Yep, and that's it. You heard itself from the former Director General how Malaysia is actually on the right track. It's just a matter of some reform, and we just need everyone to work together. So thank you so much for being our guest speaker. It was really amazing to have this opportunity and have your wise advice, because having more than 35 years of experience in the healthcare sector. So yeah, this is literally the best advice you can get actually. So thank you so much.
Thank you very much. Thank you for having me. Thank you.
Right. Thank you. That's it. Also, the viewers watching on YouTube, please just comment what you thought about this episode. What else would you like to see in future CEKU Inspires episode? Because CEKU Inspires is actually a podcast series with inspirational figures. So it's not just about healthcare, but about any industry out there, maybe fashion, education, artificial intelligence, anything. So look forward to the next episode and we'll see you soon. Thank you.